Hi, welcome to my Zoom talk. My name is Ian Spicknell. I'm from the CDC. Today I'll be talking about improved methods for estimating bacterial STI incidence and prevalence from national surveillance data. I'd like to thank Kristen Kreisel, Harold Cheston, and Thomas Gift. Without helpful discussions and expertise, this talk would not have been possible. So I want to remind you that incidence, prevalence, and recovery are all systematically linked. And if we know two of them, we can solve for the third. So use the sink as an analogy. If we're trying to estimate the flow into the sink, the incidence, and if we know the prevalence and we know the outflow, this is fairly trivial. So thinking about chlamydia, what are the different types of recovery that are possible? Well, people can clear the infection on their own, natural clearance. They can be screened based on routine checkups. And finally, if they have symptoms, they can seek treatment for those symptoms. So if we can summarize these three mechanistic recovery types, and if we know prevalence, incidence should be fairly trivial to estimate. So today I have two objectives. First, I want to compare national level incidence estimates using different types of different approaches where we have different types of data available. First, in the ideal case where we have both prevalence and case reports available. Second, where we only have prevalence data available. And third, where we only have case report data available. And then second, I'm going to compare these estimates to estimates of previous authors. Specifically, we're going to look at 2008 chlamydia incidence. It's important to note that this work that I'm showing today is building off of the work from Joanna Lewis and Peter White, where their work was focused on a UK context, while I'm showing it has a US context. But I do recommend reading their paper for information on the first use of these kinds of methods. So for chlamydia, we can think of people either being uninfected, asymptomatically infected, or symptomatically infected. And thinking about how people with infection recover from infection, well, both symptomatic and asymptomatic people can clear the infection naturally with their immune system. Second, both types of infections can go in for regular routine screening checkups. But third, symptomatic people might seek treatment for their symptoms. So thinking about case reports, let's elaborate. So what do case reports represent? So case reports are made up of people that were diagnosed with either a symptomatic or an asymptomatic infection. We can elaborate on this in the following way, where symptomatic people are they're arising from either a routine screening visit or a symptomatic treatment-seeking visit, while asymptomatic people are arising only from screening visits. So if we have estimates for how rapidly people are being screened each year, or how rapidly people seek treatment when they have symptoms, we can write down an equation to relate how screening and symptomatic treatment seeking, as well as how many people have asymptomatic or symptomatic infection. We can write down an equation for the number of annual case reports we would expect. And that's what's right here. And I'm not going to go into the details here other than just to say that we're able to write down a formula. So we've just talked about a system of equations that relate to chlamydia natural history and how case reports arise. This allows us to mathematically solve the system. I'm not going to go into detail here other than to say that it's possible with the computer. And when you know both prevalence and case report data, the number of incident infections turns into this really clean formula on the right, where the left part of this formula represents the number of diagnosed infections each year, and the portion on the right represents the number of undiagnosed infections, so people that cleared the infection on their own but were never diagnosed and reported. So thinking about these solutions, so what we've done with this method is to estimate incidence when we have different types of data available. And as we just talked about, this formula on the left is rather small and nice and pretty easy to understand. But when we have only prevalence data available, the equation, for instance, becomes a little more complicated, less readily interpretable by a human being. And when we have only case report data, this formula becomes even more complicated. It's also important to note that in situations where we don't know prevalence, in approach 3, we can also estimate prevalence using this kind of methodology. And similarly, when we only have prevalence data, we can estimate the number of annual case reports we might expect if a disease were to become nationally notifiable. We're just talking about incidence today, though. So regardless of the incidence formula that we use, what I've done to generate incidence estimates is use Monte Carlo simulation to generate 10,000 sets of input parameters, incorporating uncertainty for each parameter to then generate 10,000 estimates of incidence. We do this with using age and sex-specific input estimates to give us age and sex-specific incidence estimates. Today, I'm only going to be showing you the aggregated results, so combined by sex and age. And I've summarized outputs based on the median and the 25th and 75th percentiles, or the first and third quartiles of the resulting distribution. So how did this method compare? So in brief, Satterwhite et al. Estimated there were roughly 2.86 million chlamydia cases in men and women 15 to 39 years old in 2008. And all three of our approaches resulted in pretty similar estimates. You can see that approach one was estimating roughly between 2.6 and 2.9 million cases of chlamydia total in that year, and roughly the same for these other three approaches. But I want to caution you, it's important to think about the types of inputs that are used in these methods. So Satterwhite et al., they were obviously using NHANES prevalence, but they were also assuming some average sex-specific duration of infection. And as we just talked about, recovery is a heterogeneous process resulting from either natural clearance, screening, or symptomatic treatment seeking. And that's exactly, these other methods take that into account. So our approach one, we only had to also include data on case reports and natural clearance just because we were mathematically able to ignore those other mechanisms. But as you can see here, we do have to take them into account in approach two and approach three. So that being said, I want to say that these results are a function of the inputs we're giving them. So one parameter that we might be less certain on is how likely are people to have symptomatic infection. So in this top row of data that I'm showing, we were assuming that 50% of men had symptoms. If instead, another researcher might say, I think there's only 15% of men have symptomatic infection, well, then you can see these estimates start to diverge in approach two and approach three. That then using approach two only, they would say roughly 2.2 million cases, and approach three, they would say 3.4 million cases. So it is important that we have good input data in order to use these kinds of methods. So I want to talk just a little bit more about uncertainty. So each input is characterized by its own uncertainty distribution. Thus, each output takes into account uncertainty that we give it. And so this is an example using approach one, where we were varying natural clearance. And as you can see, natural clearance rate on the x-axis, as people clear the infection faster and faster, we are estimating a higher and higher incidence. So if you think men clear roughly after 6 months, you're going to result in a much higher chlamydia incidence. Whereas if you think men might clear, it might take them 2 years to clear infection, you're going to be on the lower end of this distribution. So why use this kind of approach? We got similar numbers to Satterwhite. Well, I like using this approach because it considers how case reporting and recovery partially depend on symptoms. It also considers how both prevalence and case report data, it uses both of these to estimate incidence. So you can plausibly expect that within NHANES, due to sampling variability, you might sample either a high or a low prevalence pocket just by chance, pocket of people. So by using an additional epidemiologic input like case reports, this can add some credibility to our estimates of incidence. Finally, our context in this model is specified by input parameters. And what do I mean by that? Well, natural clearance rate is one of these input parameters, and we wouldn't expect it to differ between time periods, whereas screening rates may differ between time periods if people have greater access to health services or if there are different screening recommendations. And so by having a screening rate being in our model as a mechanistic parameter, we take it into account directly. So how are we using this in the future? Well, we're using approach one to estimate 2018 chlamydia incidence, approach two to estimate trick incidence, and approach three to estimate gonorrhea incidence. So with that, maybe we can have a discussion. Thank you.
Hi, my name is Carrie Mock, and today I'll be discussing the validity of using diagnostic codes from administrative healthcare claims data to identify confirmed chlamydial and gonococcal infections. Start with a brief background on administrative healthcare claims data, discuss our data source, and then an overview of our project methods. Administrative claims are generated during routine healthcare encounters, such as outpatient physician visits, inpatient hospital admissions, and pharmaceutical dispensing events, and they're collected for administrative and billing purposes. Medical diagnoses are recorded in claims using standardized vocabularies, such as the International Classification of Diseases 9th and 10th Revision Diagnostic Codes, which are more commonly referred to as ICD-9 and ICD-10 diagnosis codes. Sources of administrative healthcare claims data are being increasingly used by public health researchers. Researchers commonly use diagnostic codes from medical claims to identify cases of various diseases or chronic conditions in order to estimate prevalence or examine temporal trends. These identified diagnostic codes are frequently then used to establish outcome-specific cohorts to examine potential risk factors, pharmaceutical interventions, and access to or quality of healthcare services, such as screening. For this project, we use the Optum Labs Data Warehouse, which is an administrative healthcare claims database containing de-identified inpatient and outpatient medical claims, pharmaceutical claims, laboratory data, and enrollee records for commercial and Medicare Advantage enrollees. Data is available for approximately 120 million commercially insured enrollees and approximately 9 million Medicare Advantage enrollees. Most sources of claims data either do not contain any laboratory data or only have laboratory data available for a very small, non-representative subset of the population. Within the Optum Labs Data Warehouse, at least one laboratory test result is available for approximately 40% of all enrollees. Test result availability is restricted to contracted laboratory vendors. Among our study population, we did not identify any meaningful or systematic differences between those enrollees with and without available laboratory data. Due to the widely limited availability of quality laboratory data in sources of administrative claims data, researchers often rely solely on diagnostic codes for medical claims to determine infection or disease status. And while this may not be problematic for certain diseases or conditions, such as pelvic inflammatory disease or genital warts, the case definitions for both chlamydia and gonorrhea require a positive laboratory test result to confirm infection status. The accuracy of using diagnostic codes from administrative healthcare claims data to identify confirmed chlamydial and gonococcal infections remains unknown. Our main objective is to use all available laboratory data and medical claims within the Optum Labs Data Warehouse to determine the accuracy of diagnostic codes to identify confirmed chlamydial and gonococcal infections. First identified our study population, which included all males and females aged 15 to 39 years from 2003 to 2017. We identified a total of 37.4 million eligible enrollees. Among these enrollees, we then extracted all available chlamydia and gonorrhea laboratory test results using VOINC codes. Each laboratory result record contains a VOINC code that specifies the performed laboratory test. We categorized all laboratory tests positive, negative, or other. All non-positive and non-negative values, including missing or blank, were categorized as other. Infection status was determined using test result values. So a positive laboratory test result was considered to indicate a confirmed infection. Among enrollees with at least one laboratory test result, we then extracted all medical claims within a 21-day period of interest, spanning from 7 days before to 14 days after the laboratory test result date. Each laboratory test result was linked to any available medical claims within this 21-day period of interest, and we identified all ICD-9 and ICD-10 chlamydia and gonorrhea diagnosis codes within the linked claims. For each test result, we determined the presence or absence of at least one corresponding chlamydia or gonorrhea diagnosis code within the linked claims. We then used test results as our reference standard to determine the sensitivity, specificity, positive predictive value, and negative predictive value of the chlamydia and gonorrhea diagnosis codes. Test results categorized as other were excluded from these diagnostic validity measures, as infection status could not. Now for the results. We are interested in seeing how well the diagnostic codes for chlamydia and gonorrhea correspond to the test result values. do the positive test results have at least one diagnosis code within that 21-day period of interest? And do the negative test results have a complete lack of diagnosis codes within that same 21-day period of interest? For chlamydia, we identified a total of 5 million laboratory test results among 3 million enrollees, and we had an overall test positivity rate of 3.5%. We identified a corresponding chlamydia diagnosis code within that 21-day period for 6.5% of all positive chlamydia test results, 0.5% of the negative test results, and about 1% of the other chlamydia test results. 94% of the positive chlamydia test results did not have a corresponding diagnosis code within the 21-day period of interest. And about 99% of both the negative and other test results did not have any diagnosis codes within the surrounding 21-day period. We removed the other test results in order to calculate our validity measures. The chlamydia diagnostic codes had a sensitivity of 6.5%, specificity of 99.5%, positive predictive value of 33%, and negative predictive value of 96.4%. The exact same process for the gonorrhea test results and diagnostic codes. We identified a total of 4.7 million gonorrhea test results among 3 million enrollees. We had an overall test positivity rate of 0.7%. We identified a corresponding gonorrhea diagnostic code for 25% of all positive gonorrhea test results, and less than 1% of the negative and other gonorrhea test results had a corresponding diagnosis code within the 21-day period of interest. 75% of the positive gonorrhea test results did not have a corresponding diagnostic code within the 21-day period of interest. About 99% of both the negative and other test results did not have a gonorrhea diagnosis code within the period of interest. Again, other test results were excluded from our calculations. Gonorrhea diagnostic codes have a sensitivity of 25.4%, specificity of 99.7%, positive predictive value of 75.4%, and negative predictive value of 99.5%. What does this all mean for using administrative healthcare claims data to identify chlamydial and gonococcal infections? We observed extremely high specificities for both the chlamydia and gonorrhea diagnostic codes. Most chlamydia and gonorrhea diagnostic codes we identified were linked to positive test results, which suggests that these diagnostic codes in medical claims likely represent confirmed chlamydial and gonococcal infections. However, we also observed extremely low sensitivities. The vast majority of laboratory confirmed infections did not have a corresponding diagnosis code within the 21-day period of interest. We expanded the period surrounding the laboratory test result, and expanding beyond 21 days did not increase the number of corresponding diagnosis codes identified. Therefore, relying solely on diagnosis codes to identify chlamydial and gonococcal infections in administrative healthcare claims data will substantially underestimate the burden of disease. Furthermore, using a diagnostic code-only approach to identify cases in order to establish outcome or disease-specific cohorts will likely introduce misclassification bias. In this study, solely relying on diagnostic codes would have misclassified 94% of laboratory-confirmed chlamydial infections and would have misclassified 75% of laboratory-confirmed gonococcal infections as non-infections. Whenever available, we recommend using laboratory data in public health research to identify chlamydial and gonococcal infections, or using a laboratory data combined with diagnostic code approach when working with administrative healthcare claims data. Thank you very much. I'd be more than happy to take any questions.
Welcome to the STD Prevention Conference 2020 Virtual Edition. I'm Dan Newman, an epidemiologist in the Division of STD Prevention, and I will be presenting for you today how much syphilis is due to reinfection. Data from Florida and Louisiana, 2000 through 2018. Most people working in STD prevention are well aware that syphilis rates have been rising for many years. And MSM have been the group most effective in this current rise. Florida and Louisiana consistently report high rates of infection, therefore providing an opportunity for us to look for a group that we could possibly target for rescreening to influence the burden of infection. So let's see how we went about our analysis. We evaluated all syphilis records, all stages, for males and females 15 to 70 years of age, reported in Florida and Louisiana from 2000 through 2018. We examined the demographics of cases, including repeaters. And for our study, a repeater was an individual that was reported with syphilis 2 or more times between 2000 and 2018. And we calculated the percentages of cases that were repeat infections by gender and HIV status. We also did a sub-analysis looking at individuals that became infected in 2015 for the first time to see how many became reinfected by 2018. And what do we find? In the first graph, on the left side of the page, we see that there were 107,405 individuals diagnosed with syphilis at least once over the 18-year period. 94,860, or 88%, were diagnosed one time. 12,545, or 12%, were repeaters. In the second graph, we see that these 107,405 individuals were responsible for a total of 124,827 infections. 17,422, or 14% of these total 124,827 infections were from repeaters. As we see from the table, men were the majority of syphilis cases reported. 66% were responsible for single infections, and nearly 88% of the men were repeaters. As far as race, ethnicity, all races were represented, whether it be in a single episode of syphilis or as a repeater. So not a particularly good variable to use to try to find who to target for an intervention. Age was not as useful as well, as repeaters look nearly the same as people with a single diagnosis of syphilis, with most cases being found in the age range of 20 to 50 years. And concerning HIV status, 19% of the people with a single episode of syphilis were HIV positive, whereas 55% of repeaters were HIV positive. This is a huge representation. As for a couple of other items about repeaters, the range of infections reported from repeaters were between 2 and 10 diagnoses between 2000 and 2018. The median time to second infection was 2.6 years. The mean time was 3.6 years. So for the sake of expediency, Here are results from some of the last few years of the study period. There's been an increasing trend in the percentage of syphilis cases each year by repeaters. In 2010, 11% of all syphilis cases were from repeaters. By 2013, 16% of all cases were from repeaters. And in 2018, 1 in 4 cases, or slightly more than 1 in 4 cases, were from repeaters. Among males living with HIV, the percent of cases from repeaters has also been increasing. From 28% of the cases in 2010, all the way to 50% of the cases in 2018 were from repeaters. And in our subset analysis, where we looked at people with their first infection in 2015 and followed them or looked for them for 3 years for possible reinfection, 1 in 8 of the people diagnosed in 2015 were reinfected by 2018. Almost 1 in 5 males were reinfected within the 3 years. And for HIV positive males, nearly 30% became reinfected within 3 years. Our study has some limitations. We had incomplete data on sex of sex partners, so some MSM were not classified as MSM. And we did not capture all syphilis cases as systematic testing was not done. And there was also the possibility of outmigration of residents that could underestimate reinfections. So in conclusion, an increasing fraction of syphilis diagnoses was from persons who had had it before. 26% of all cases in 2018 were from repeaters. This fraction is much higher in some subgroups. Fully 50% of HIV positive MSM in 2018 were repeaters. MSM who have syphilis, especially HIV positive MSM, are at very high risk of getting syphilis again and should be frequently rescreened. I want to offer thanks to my co-authors, Antoine Brantley of the Louisiana Department of Health, James Mathias of CDC and the Florida Department of Health, Mohammed Rahman of CDC and the Louisiana Department of Health, and Tom Peterman of CDC in Atlanta. For this analysis would not have been possible without their assistance. Thank you for listening, and I hope you enjoy the rest of the conference. Have a good day.
Good morning, good afternoon. I'm Stephanie McLaughlin. I'm coming from Seattle King County and the University of Washington to talk with you about pharyngeal gonorrhea among heterosexual men and women. Little is known about pharyngeal gonorrhea in heterosexual men and women in the era of NATS. Much of the information we have is from decades ago when culture was the standard. There's growing concern that GC sustains community transmission and is a reservoir, particularly in these groups, which we do not normally screen or test. Furthermore, there's emerging data that GC can be transmitted through kissing. The aims of this study are threefold. Number one, what is the burden of pharyngeal GC in heterosexual men? Otherwise, men have sex with women exclusively, and women in a sexual health clinic. Number 2, how much GC would be missed by urogenital testing alone? And number 3, what sexual behaviors are predictive of pharyngeal GC in men who have sex with women? And is kissing involved in the transmission to the pharynx? This study analysis was conducted over the time period below, February 2017 to May 2020, in a public health Seattle and King County sexual health clinic. In February 2017, pharyngeal testing was suggested for all contacts to gonorrhea in men who have sex with women and women who report giving oral sex. This was further broadened in a change in clinic policy in 2019 September, when pharyngeal testing, regardless of oral sex behavior, was conducted in contacts to GC in men who have sex with women and women. Furthermore, the computer-assisted self-interview, which normally collects detailed sexual behavior from all patients at intake, had questions added about kissing in September. And generally in the clinic, as well as over this study period, clinicians were able to use their judgment in female non-contacts to GC when determining who to test at the extragenital sites. The data from this time period conducted a descriptive analysis of the visits over this time period in men who have sex with women and women who are tested for GC at any site. We looked at all women who are tested for GC, as well as contacts who are women and men who have sex with women who are contacts to GC. This analysis was mostly univariate, looking particularly at GC positivity at the pharynx in regard to oral sex behavior, as well as some other demographic features. There were 8,500 visits overall in which men who have sex with women and women were tested for GC at any site over this time period. 3,800 of those were in men who have sex with women who were tested at any site. About 4,750 were in women who were tested at any site. 117 of those women were contacts to GC. 52% of those contacts were tested at the pharynx, and 38% of those contacts were women were positive at the pharynx. That leaves 4,600 non-contacts that were women who were tested at any site for GC, and 690 of those who were tested at the pharynx. Of those tested, or of those women who were not contacts, 6.5 of them were positive at the pharynx. 134 men who were contacts to GC who reported only having sex with women were tested. 28% of those tested were tested at the pharynx, and 22% of those male contacts tested were positive at the pharynx. Looking further at the burden of disease in contacts in particular, a greater portion of the male contacts were tested only at the urogenital site, with only 35 of 134 being tested at both the GU and the pharynx. Of those tested at both sites, 28% were positive. Looking at the female contacts, about half were tested at the urogenital site alone and half were tested at both sites. Those tested at the urogenital site alone, 34% of them were positive for GC overall, and those tested at both sites, 46% were positive for GC. Looking particularly at the female contacts that were tested at both sites, there were about 12% who tested positive only at the pharynx. This means that we would miss 18% of the total positives in the female contacts if we would have only tested at the urogenital site. Looking at the men, similarly, about 36 of them were tested at both the GU site and the pharynx. And of those, 8% were positive only at the pharynx. This leaves a similar percent, about 17.6 of the total positive contacts in men who have sex with women who would have been missed in the absence of pharyngeal testing. This is a bit of demographic breakdown of both the men who have sex with women who are contacts to GC as well as the women who are contacts to GC. You can see they're predominantly white, of non-Hispanic origin. And one thing to note, which we found, is that giving oral sex was much more likely in women who are positive at the pharynx than women overall or women that were negative. You can see that in this graphic that giving oral sex was statistically significantly associated with GC positivity at the pharynx in female contacts to GC. In fact, 0% of those who did not give oral sex were positive at the pharynx. We did not see this association in the men. An equal percentage were positive when tested at the pharynx in respect to those who did or did not give oral sex in the last 2 months. Switching gears a bit to look at all of the women tested, which is a much larger group, an N of 751, you can see the racial breakdown as well as some other demographics. Women who are positive at the pharynx tended to be younger, and they also had the association of being more likely to have reported giving oral sex if they were positive at the pharynx. You can see that in a similar graphic representation here, and that giving oral sex was statistically significantly associated with GC positivity at the pharynx in women who did give oral sex in the last 2 months versus those who did not. This association held true in a multivariate logistic regression analysis, where the odds ratio was 4.6 for GC positivity at the pharynx when you compared women who reported giving oral penile sex compared to those who did not report giving oral sex. This was adjusted for age, ethnicity, race, number of sexual partners, and transactional sex in the last 12 months. What about kissing? So we had pretty minimal data on kissing because of the timing of the COVID pandemic. But we did have 3 men who have sex with women who denied giving oral sex but reported kissing and were GC positive at the pharynx, hinting that this might be a mode of transmission of GC to the pharynx in heterosexual men. We don't have any similar data on women yet. The limitations of the study, of course, this is a retrospective analysis, a small sample size, particularly in contacts and especially in those with kissing data. There's some missing data regarding oral sex behavior and a few others listed below. Going back to our aims from the beginning, the 3 aims. Number 1, the burden of disease, of GC positivity, of GC infection at the pharynx in all of the women tested was about 9%. In female contacts, however, it was much higher, 38%. And in men who have sex with women who reported being a contact to GC, about 22% of them were positive at the pharynx. This is very much in line with the data that was gathered by our colleagues in Australia. The citation is noted below. Number 2, how much GC would we miss if we only did urogenital testing? So in the absence of pharyngeal testing, about 18% of all positives in contacts of men, contact to GC in the men would have been missed, in the men who have sex with women exclusively. And about 18% of the positive infections in women would have been missed in the absence of pharyngeal testing. Lastly, giving oral sex was associated with positivity at the pharynx in women, but not in men. And lastly, some men who denied giving oral sex but reported kissing were positive at the pharynx. In regard to conclusions, as it is common in these groups, pharyngeal GC likely represents an underdiagnosed reservoir. And as such, we suggest pharyngeal testing in all men who have sex with women and female contacts to GC. However, more information is needed on the burden of pharyngeal GC in all comers and men who have sex with women and women who are non-contacts to GC in order to guide screening recommendations in these groups. Furthermore, it's unclear what behavior is associated with pharyngeal GC in heterosexual men and if kissing could be involved. This should be actively investigated further. And with that, I'd like to thank my co-authors, collaborators, and mentors. Please feel free to contact me with questions, and I appreciate your time. Have a nice day.
Hello, everyone. My name is Casey Pinto, and I'm an assistant professor at the Penn State University, and I want to thank you for taking the time to watch my session, Annual Out-of-Pocket and Total Healthcare Costs for STD Treatment and Screening. I'd like to acknowledge my co-authors listed below from both the Penn State University and the Ohio State University, and I'd like to acknowledge Dr. Harold Chesson for his assistance in helping to streamline this topic. A little bit of background on this research topic. The reason why we chose this is because as an STD researcher, we spend most of our time in our introductions citing all the cost studies that are out there. And what I've found is that they tend to, A, they're outdated, and B, they're limited in their breadth or their scope of what they actually cover. And one major thing that's missing amongst all of these studies is the out-of-pocket cost. And the big reason we want to look at this is, as a clinician, I know that my patients don't return for rescreening if the cost is too high. And we have evidence that shows if the out-of-pocket cost is more than $30, these patients are less likely to return to get rescreened. So in order to conduct this study, we did a retrospective cross-sectional analysis of the IBM Truven Health Analytics Market Scan database using 2015 and 2016 data. 2017 data was not available when we initially conducted this analysis. Actually, it's not available when I'm recording this, but it should be available hopefully by the time you watch this presentation, at least to our university. We use ICD-9 and ICD-10 codes because the transition from ICD-9 to ICD-10 occurred in 2015. And the one key difference here from most cost studies is we looked at the annual cost per patient. And the reason for looking at annual is because while it's important to have the cost per visit, some of our patients are repeat offenders, or they come and get rescreened outside of the window we typically use for cost per diagnosis. But we did incorporate that a little bit into some of our definitions, and we'll talk about that right now. So total cost and out-of-pocket costs are fairly self-explanatory. The total cost is all costs related to that diagnosis per year, excluding the out-of-pocket. So that's everything that the insurer pays. Whereas the out-of-pocket, this is everything the patient's responsible for paying for. So it could be co-payment, it could be co-insurance, and it could be deductibles. I know for this group, I don't specifically have to go over what chlamydia, gonorrhea, and syphilis are. And I've used the most common ICD-9 and ICD-10 codes, and these have actually been used in the cost literature before, so I won't beleaguer you with that. The one thing we did exclude from syphilis, which is pretty consistent across the STD literature, is congenital syphilis because of the chronicity of that condition. The other factor that we think kind of sets this study apart is that we looked at diagnostic testing of possible cases. And I see this has been done before, but again, as a clinician, I know that when a patient comes in with penile discharge or vaginal discharge, I am not diagnosing them with chlamydia or gonorrhea because I do not know if they have that unless they tell me. My partner has chlamydia. I started with this after I had sex with my partner. So we looked at some of the most common ICD-9 and ICD-10 codes that are used by biller and coding specialists and are taught to providers to use. So penile discharge, high-risk heterosexual behavior, high-risk homosexual behavior. All of these codes were included, but we couldn't just use this code. We had to use a way to make sure that STDs are being screened for. So we use CPT codes such as chlamydia and gonorrhea, the chlamydia and gonorrhea testing codes. So this would be our high-risk group. So groups that may test positive, most likely test positive, but may test negative, but may test positive and not actually have a diagnosis in the system that year. So this likely would represent a one point in time. So maybe your cost per testing per once. And then this would be our low risk group, this screening during routine gynecology visits. We know that during well woman exams, STD guidelines say we should have STD screening, and that's what this is meant to capture. So anyone who has a well woman visit code, in addition to CPT codes for chlamydia and gonorrhea, that's what this code would represent. So those at low risk because they didn't come in with a complaint of vaginal or penile, well, in this case, it would just be vaginal since we're doing gynecology visits, or high-risk hetero or homosexual behavior. So moving on to results, we'll first look by age. So as you can see here, this is the total cost in US dollars, and syphilis across the board is the highest, with between $400 and $830 per year per person per diagnosis. So with syphilis, we suspected this because with syphilis, you're going to have to rescreen these patients. Once they get that diagnosis, we're rechecking them 3 months, possibly even 6 months, or if they are co-infected with HIV, which would also be a driver behind this increased cost, we would be rechecking them at least annually once they've been cleared. The other factor here is the treatment for syphilis is much more expensive than the treatment for gonorrhea or chlamydia. The bicillin injection is about $700 to $800, so we suspect that would be one of the increased drivers. The other big factor we noted here is that the population 50 to greater than 60 is much, much higher than the population under 50. And that's likely because they may have some comorbidities, but it could also be that we're not screening for syphilis in these older age groups. And if they are diagnosed, it's a later diagnosis, or they're diagnosed as neurosyphilis, which requires an inpatient stay, requires an ophthalmologist visit. Now, the next category are high-risk STD screening group. We're seeing costs of between $90 to $95 for the insurer. So that's actually pretty good, especially compared to your syphilis, chlamydia, and gonorrhea. And then those coming in for a low-risk visit are about $80. So it's only $10 to $15 lower for a low-risk visit compared to a high-risk visit. Now where we see the numbers jump up exponentially is chlamydia and gonorrhea, a diagnosis of that. And this may be that they've gotten reinfected, but we know that this is likely not the cost of the actual test, since in our STD screening and in our gynecology visit, they also had that screening done. This could be because these patients, regardless if they had chlamydia or gonorrhea, were given a Rocephin shot early on before their diagnosis of chlamydia. So they may have received Rocephin, which would increase the cost. Overall out-of-pocket cost, again, syphilis is the most expensive, so it's no surprise that we're going to see that syphilis is the most expensive. But what is surprising is that the greater than 60 age group has a much lower out-of-pocket cost. And I say much, $10 to $15 out of pocket is likely a big deal for some people. And this may be because these patients also are dual enrolled with Medicare. So some of these out-of-pocket costs are covered with Medicare, or they ended up inpatient and have lower out-of-pocket costs. STD screening group out-of-pocket cost is less than $15, which is fantastic. And then our patients who are being seen for well women visit, the cost is very low. And some of this is likely due to Obamacare, since those well women visits should be covered at 100%, but patients may have to pay for the testing. So $6 to $7 is very reasonable. Patients are likely to be rescreened. Where we start to see issues is with chlamydia and gonorrhea. These costs of between $50 and $80 out of pocket is high, especially for patients who are on low income or don't have a lot of money to spend to get retested, and this may deter patients from being retested. So conclusions, we're seeing out-of-pocket costs for high-risk screening and low-risk screening as something that's very affordable for patients and something that they may come back and get rescreened. What is concerning is the high out-of-pocket costs. Even though this is an annual study, those high out-of-pocket costs are concerning because it may be a deterrent for patients to come and get rescreened. Some future directions is to think about ways that we as a society can help decrease some of these costs. One would, as I'm sure you can all attest to, is to advocate for more funding for our STD clinics that are safety nets, since that may encourage patients to get rescreened. And there's also some other economic analyses that should be conducted. Like one is looking at the cost of screening in pregnant women, or separating out patients who have HIV and looking at the cost of STD screening in that group to document the cost-benefit ratios. So if anyone has any questions, I will be at the open seminar, and I'm excited to talk to all of you. But if you can't make that at that time, my email's here. I answer as randomly as everyone else does. So again, thank you